Welcome to Berries in the Interim podcast, where we explore the cutting edge of innovative clinical trial design for the pharmaceutical and medical industries and so much more. Let's dive in.
All right, welcome everybody back to In the Interim. I am your host today, Scott Berry, and I have a guest with me today, and we've got a number of topics to get to, but first let me introduce our guest for today. Michael Harhay, who is an associate professor of epidemiology, medicine, and statistics and data sciences. There's a lot of "and" in there, and we'll talk about that. By the way, the University of Pennsylvania at Penn. Michael has an interesting history at Penn. We'll go through that. He's also the founding director of the Center for Clinical Trials Innovation, which specializes in statistical design, analysis, and interpretation of large randomized trials and cohort studies. We'll talk more about that. But let's first talk about how you got here, Michael. You have a PhD in epidemiology from Penn, as well as a master's in statistics as well. So you have multiple degrees from Penn. So let's talk a little bit about how you got here, a little bit about your history to this point, and welcome to In the Interim.
Great. Scott, thank you so much for having me. It's a real pleasure to be here. I'm a big fan of the podcast. So I've written a lot of personal statements. I've told this story a lot of times, and I wish it was a little bit more romantic and straightforward, but I've always kind of believed in this concept of a calculated drift. And I think my calculated drift towards academia started at freshman, sophomore year of college. I went to a small liberal arts school outside of Pennsylvania, for those not from the US. It has about 2,000 students. The name was Muhlenberg. And I just really enjoyed it. I like being in an academic setting. I majored there in neuroscience and philosophy and very much wanted to stay and do more academics. And I liked the multidisciplinary opportunity of being in a university setting where I could dabble in the sciences and the humanities and philosophy. And I didn't really know how to do that. So with some Googling, I found Penn's bioethics program, which saw some bio related to neuro, and I saw some ethics related to philosophy, and it seemed like a good next step. So I came to Penn the year after graduation. So this is 2006 at the time. And I quickly found out that you could pay for your graduate degrees if you were a full-time employee. So I got a job in Penn's pulmonary and critical care division, basically working on patient registries for pulmonary hypertension. And I just started taking classes and learning how medical research worked, clinical research worked, alongside a bioethics degree. And I was really hooked on the production of data and how data was used. And I didn't quite know how to transform that. So I just kind of kept on taking classes over multiple years until I met a young fellow who transitioned onto faculty, and I joined, I started my PhD in 2013 in epidemiology. So during that time, I picked up a couple degrees in bioethics, public health, and demography, and then ultimately my PhD. But a lot of that, I think, was just me experimenting with different ways of doing human level and population level research and trying to figure out what I found attractive.
Interesting. So at what point in there did the quantitative side of that? You had philosophy and bioethics, and it sounds like initially maybe in the pulmonary and critical care, you were doing some data stuff. At what point did the quantitative side of this interest you?
So I was always handing off data sets, and then they would come back from a PhD level statistician or collaborator, and there were always gaps where I was kind of asked to do smaller things in Excel. And I think I increasingly just started to teach myself how to code, first informally, and then I started taking classes in 2009 where I was first exposed to Stata. I know some users and listeners may not be a big fan, but I just really enjoyed coding. And then I joined an analytics group in 2011 where I started to really get to work with large data sets, and I loved it. I enjoyed nothing more than waking up, making coffee, and just coding throughout the day. And I purchased a bunch of books back then. And I increasingly just got really interested in transforming data extracting things from it, but very aware that I needed some type of formal training to really translate into a set of tools that I could actually extract things from.
Interesting. So if we're counting here, just to make sure I have this right, so you have 4 master's degrees and a PhD. Do I have that right?
Yes, that's correct. No more for now. Stopping.
Okay. Okay. All right. We'll never say never in that. All right. So I asked you how you got here, and now so let's talk about here. What is here? So you're an associate professor of epidemiology, and you founded now, upon reaching tenure, you founded the Center for Clinical Trials Innovation. Tell me a little bit about the Center for Clinical Trials Innovation.
Yeah, so it's very much a culmination of about 10 years of being exposed to different topics and trials. So during my PhD in epidemiology, I had a little bit more of an apprenticeship type where I worked under a physician scientist, an MD PhD, who ran both behavioral trials, but also comparative effectiveness trials. And behavioral trials tended to be large multi-arm trials of multiple different contrasts. And then we had a couple critical care-based trials in our healthcare system. And both of them kind of brought me into a lot of different questions that we can return to, but some of them being just dealing with multiple intervention studies and multiple comparisons and thinking about what the risk of false answers was. And that always kind of bothered me when we were doing behavioral things. And then on another side, we were doing studies in our healthcare system, and there's inherent clustering, inherent time factors. There's also fixed sample sizes, and you can't really control them. So you're trying to think about how to do things best. And then another area of interrelated research that I spent a lot of my time thinking about that's become a big driver in the center is how to deal with not fully observed outcomes, where we call it informatively truncated outcomes. So in the ICU, we're very interested in questions like duration of mechanical ventilation or how long an individual is in the ICU. But if a percentage of those people die, you don't have kind of a clear treatment effect estimate comparison, because for some people, time in the ICU is time to death, and for other ones, it's time to discharge. And at the time, I didn't really have the ICH-9 framework for intercurrent events. So a lot of my dissertation was trying to make sense of that in a more immature way. But after that, I did a K99R00 award, which supported my postdoc, and then became my early career faculty award, supporting me in my time at Penn. And during that time, I started to build out the work on intercurrent events, and the estimand framework became more popular. And I started to get involved in more formal ways in trials, increasingly as like an MPI in a trial, where I would work as a kind of methodology lead with a clinical lead. And that started to lead to a lot of research questions that we didn't really find answers for in the literature. And I can talk more about them, but over the last 4 or 5 years as an assistant professor, I started to feel like we were trying to answer questions where the methodological guidance for how to answer those questions wasn't clear. And what I wanted to do with the center was to kind of create a way to answer those, but also to support a training hub where we could train young academic trial methodologists. It tends to be mostly statisticians thus far, to these real world questions and to kind of advance their careers. And that's what I'm trying to put together at the moment.
Very nice. So I want to come back to this question of measuring things, critical care. Very interested in endpoints in critical care. About the center now. So you have dedicated personnel to this. You have other individuals at Penn that are part of this center. So this is just a relatively new center, but you're looking to expand its impact and its role, it sounds like?
Yeah, I think it's a little bit of it kind of existed in a non-formal way on one hand, and the other hand is like, if you build it, it will come. So yep. We have 2 methodology grants. One's an R01 from NIH and one PCORI, and that supports like formal statistical methodology. We mostly focused on this question of intercurrent events and composite outcomes. And then we have several trials that we support across a continuum, some just being consultative support, and others where I'm the formal PI, and we have someone on my team serving as a primary statistician. And these are all health system-based trials. So I've been using those different funding mechanisms to kind of build a base. So we have a formal PhD, staff statistician, 2 postdocs, and then a lot of collaborators who are really into the cause and are helping me bring on mentees and also bringing on their own trainees in different stages. So it's starting to become a little bit of a critical mass and get some inertia. And it's kind of really cool to watch. I don't know exactly what it will become, but there's a lot of people who want to do more innovative health system trials, and that's become very much our focus. And increasingly, there's just new opportunities and new venues that we can expand ourselves. And I'm very strategically trying to find cool internal partners. And it's been a lot of fun to kind of create and just kind of be creative on a vision, like something like that. But it's also the calculated drift concept.
Yeah. Very nice. So I'm very interested in this idea of healthcare-based, health system-based trials. Tell me a little bit about what that means for Penn. Do you have a set of hospitals and you're doing comparative effectiveness within this? So it's part of caring for the patients, but also learning what is available for Penn?
Yeah, so we have several trials within Penn, and also we collaborate with several external partners. So let's start with Penn because it really, I think, highlights where I think the innovation kind of comes into what we do. So Penn Medicine has 6 hospitals, depending on how you count, about 40 exclusive primary care practices, and then a handful of other practices. There's obviously outpatient clinics, all different types of things in the greater Philadelphia region. And that is a remarkable opportunity for experimentation. You can improve primary care practices, you can improve in-hospital practices, you can improve ED delivery, and we have multiple different ways to experiment. We also spread across wide geographic areas with different patient populations. We're serving different patient populations. So going out towards rural Pennsylvania, going into more dense northern New Jersey area, and then obviously you have different practice variation. So we team with a couple different groups. At the moment, it's principally critical care, primary care practices, and we have a specific center called the Center for Healthcare Innovation and Transformation that also is collaborating across the health system, trying to help different service lines, like obstetrics or oncology, improve or do things that they believe will improve the delivery of their care or just sometimes have a good return on investment. So I can give you a couple examples of some projects we've done that I think are kind of neat in that vein.
Yeah. No, so I think this is actually the future. Where if you think about it from a perspective, who do we learn from about right ways to give treatment, what treatments work or not? We learn from such a small fraction of patients in clinical trials, randomized. But yet these decisions are being made every day. And I think critical care is a really nice area. And I'm echoing what other clinicians tell me. I'm not an ICU doc, but largely care is random. They don't know a great deal about this. They're individually perhaps learning at a patient level, but none of this, there's a huge set of things that are done that we don't learn from that we could potentially make this a learning healthcare system. We could treat them better. We could learn, extend those. I was involved with UPMC, which has a large extent of hospitals west of you, Pittsburgh-based, but even through that, where even in elective surgery, there's a great deal of things that they really don't know about how to care for nausea and vomiting, how to, what should you do before surgery, all of these things that could be learned as you treat in that. So I'm fascinated. You said you had a few examples of that. I'm fascinated by what some of those examples look like.
Yeah, I think some of them are so elegant and clever, and they have such profound changes. So I'll start with them, and we can go through them in different depth if you find them interesting. So we just had one paper published in JAMA Surgery, where the idea was to change how many opioid pills the EHR default ordered. So if you come into the ER and you have a major injury, the default number of opioids may just be 30. So we changed it to 10 and then asked how frequently do people come back for new medications? How often do people complain that it's insufficient? And we found that generally speaking, very few physicians overrode the change of the default prescription number. And we didn't have a large number of complaints to the ability we were able to follow up patients. So opioid use is a big challenge in the Philadelphia region. And one of the goals is to keep opioids where they should be ideally, and to those who need them. So simple kind of default changes in our EHR are something we try to leverage a lot. We've used similar mechanisms to increase the delivery of palliative care, also to make the delivery more targeted. So it is a finite resource, and you need to send the physicians out to where they can ideally be most useful and have the largest impact. We've used it to kind of triage people in our primary care practices. We have used it to, if someone's come back several times and just has a high blood pressure that's not coming out of control, maybe we need to identify them as someone who's high risk for a genetic disorder and should be screened for a different type of therapy. So we are trying to find ways to improve. And this is not really me thinking of the clinical ideas. I'm kind of helping with the design, but these are the questions we get is like, this is something that we're not doing in the standardized fashion. It's kind of an easy win if we could do it better. Can I test it and create some evidence base around it? And people are really clever. Clinicians really see how the things work. And it's very neat to hear about the human computer interface of the EHR and ways to modify it. And I'm helping kind of put a statistical paradigm around that to test it.
So interesting. So the question of how many pills is the initial order, the default order within that, that's done at a cluster level or a hospital level, it sounds like, not a patient level?
Yeah, so for a lot of reasons, we tend to do the vast majority of our research at a cluster level. It tends to be a practice level. We're a hospital level. So we have 6 hospitals in our system or 40 primary care practices. So we tend to do cluster level randomization. We also do provider level randomization, though there can be challenges of that in different fields. Some just shift specialties, just have the way the patients are exposed can potentially shift. So we tend to mostly randomize at the cluster level. We do some individual level patient randomization, but that's not kind of our, it's a minority of what we get to do.
Yeah. So I'm interested as you do this in a number of trials that have tried to be embedded within the healthcare system, and that there's a whole range of what embedded means.
Sure.
But in that setting, once you're addressing one question, you're collecting the data and you're looking at it, it becomes, I don't know, intoxicating is a pejorative word, but it becomes intoxicating to say, we've got a captive set of patients and questions. Let's investigate 2 things rather than 1. Let's do factorial things. Let's do 3 things. It's almost free to add a 3rd thing once you're doing 2 and 4 sort of thing. Has that happened within these trials?
Yes, because a lot of the interventions we're doing are not usually single component interventions. They tend to be multiple components. And there's a couple scientific questions in a multi-component question just by default. So do all the components need to be there? Is it the existence of one? Can we get a little bit of an effect by adding one? And then if we add a second one, do we get kind of an additive or a multiplicative effect? So we play a lot in cluster designs, cluster randomized trial designs. And just for listeners who may be unfamiliar, that means that we're randomizing groups of people. So groups of people based on what primary care practice they come into, what week they get their critical care, what emergency department they come in our healthcare system. So we are playing around with a couple different component designs where we are trying to look at all these different questions. And so yes, the large number of questions tend to be embedded in a lot of our trials. And it is largely to try to decompose different contributions of different strategies to improve an outcome.
Yeah, very nice. What's come up in a number of ours as well is combining together cluster randomized with individual randomized in a factorial way. Have you run into that?
So we have our first trial under review at NIH where we have cluster level randomization of clinics and then individual level randomization within patients. So we are just kind of this two-level cluster randomization. I can't take credit for the design. One of my primary collaborators in my cluster trial, Oracle, is Fan Lee, is a biostatistician at Yale. So he's a big thought leader in our group and contributes very heavily in our program. So he's developed cool designs like that. So I'm very hopeful that when NIH funding kind of comes back online officially, that will be one of the cool things we get to really roll out.
Very nice, very nice. You talked about endpoints. I imagine in all of these endpoints are interesting, but let's go back to the critical care scenario. And yes. I bring this up because my call last night we have a global call for REMAP-CAP. The REMAP-CAP is a trial that is community-acquired pneumonia is the CAP part of it. And so we generally have hospitalized patients in ICUs. And we for 10 years now have talked about what's the right endpoint. It's continually the discussion. So it sounds like you spent a good bit of your dissertation on this question of this and still addressing this question today. And it's interesting you brought up the role of E9 and all of this. So let's talk about critical care endpoints within this.
Yeah, I've spent, I think, at this point, a quarter of my life trying to solve this question. So,
yep. We see a lot of this question, and I've kind of fought hard that even they'll ask questions about what is the distribution of length of mechanical ventilation for those that don't die. So let's set up a scenario where it's intensive care. You can go back to COVID, and some individuals come in and they're on life support, let's call it. And you're interested in the length of life support. You're doing interventions to them and you're wondering that. And some patients die during that process. If you're really interested in the length of organ support, what do you do with that patient within the setting? And it's always struck me as hugely problematic when you censor that out or you remove patients that die and you only look at the length of organ support. And you've pulled people out that, in fact, are the worst outcomes. Within that, it's a really hard question without somehow including mortality as part of that.
Yes, I couldn't agree more. You want me to respond?
I want you to respond. Yes.
Yeah. So I think this question has very profoundly shaped me as a methodologist. I think it shapes the way I think about questions. It's been very transformative for me, and I can just give you some cliff notes about that, and you can tell me which part you want to jump in most. So as a PhD student, at that time, was causal inference. It was around, of course, but I don't think it was as popular as it was today. And the Estimand's framework, especially in current events, I didn't have a formal framework. So at the time, I was just thinking about it as, we have a distribution in front of us. How do we model that distribution? And it's, tends to be a little bit of a negative binomial distribution, kind of gamma, where you have a bunch of people early who are discharging in a long tail. But then you have people that die. So this really kind of complicates the question. So for people, as I mentioned before, people who die, it's not duration mechanical ventilation, it's time to death. And for those who survive, it's their time to discharge. So I spent some time exploring what are options. And the big one at the time was competing risk models. And the challenge of competing risk models, just like survival models, is they kind of make this assumption about what would have happened if people didn't have the event of interest. And it's just counterfactual. And obviously people are not going to not die. So it didn't really make conceptual sense. And my PhD mentor at the time said, yeah, competing risk may be a modeling solution, but it's conceptually invalid. So then I moved on to this concept of joint modeling, where you would kind of model the longitudinal probability being on, or the daily likelihood of being on a ventilator. And then you can also model the competing events separately and then pull them together. And I remember my other mentor said, but now we're thinking about a counterfactual probability distribution and being on a ventilator that would have been observed if people never died. And that was the first time I was really exposed to this concept of the hypothetical scenario for estimands. And I never found it conceptually digestible. So then I spent a few years kind of getting into this estimand called the survival average causal effect. And I find a lot of attraction here, but it has a limitation. So I can talk about that for a minute. And then,
Yeah. So let's describe what that is.
So it's a clever estimate. And the idea is that at the beginning of a trial, you have these latent strata of individuals. So the simplest scenario is you have some people that would always survive to the end of the trial. And let's just say this is a 60-day follow-up. You have some people who are very sick and are going to die. And then you have these two middle strata. And these are people who, that last strata is two people, where they would die regardless if they were exposed to the intervention or the control arm. Then you have these two middle strata, and you have some strata that will only survive if they're exposed to the intervention. And then some people that will be harmed by their intervention, so they would only survive if they are given the control. And what you want to be able to do is identify these always survivors, this fourth strata. And these are these people that would always survive to the end of the trial, regardless if they received intervention or control. And the concept there is that if you can isolate this strata of people, or stratum, then you can say, this is the average causal effect among these individuals. And I think there's a lot of kind of conceptual attraction there, but the obvious kind of issue is that you're no longer looking at the full randomized population. And that raises issues with the ITT. It's also a much smaller population, and critical care trials are already small. So I like that, and I spent a lot of my life developing statistical methods to estimate that quantity, because I do think it's informative, and I think certain clinicians like it, and it's viable and attractive, just as additional information. I think about it as like a subgroup type of analysis now that's informative. But for the last several years, we've increasingly been working on composite outcomes, which is the kind of last third intercurrent strategy. And we spend a lot of time trying to think about what is a statistically valid, patient relevant, and clinically interpretable composite outcome. And my colleague Chris Lindsell.
Yep. So let's pause here for a second, and then we'll go to Chris. So a composite, you talked about hypothetical, and so largely in the estimand, we're trying to identify what would have happened if this intercurrent event of mortality wouldn't have happened in order to model that. A composite outcome is saying we're actually not going to even make mortality an intercurrent event anymore. We're going to make it part of the endpoint. That
Correct.
Somehow we're going to create a single endpoint where mortality is part of that endpoint. And that's making it a composite within that. And so that's what you mean by that.
Correct,
Okay.
yeah.
So what might that look like in the intensive care? What's a composite strategy of mortality and organ support in the ICU?
Yeah, so I think the most traditional one, I know you have used a variation of this in some of the Remap CAP platform, and many trials do, is what we call ventilator-free days, or a wider capture as organ support-free days. And the concept here is that you have a distribution of days over a duration of period of time. So let's just take 30 days. And for everybody who survives, you have the number of days that those people didn't require mechanical ventilation or some other modality of organ support. And then for those who die, they tend to get a fixed value. Variations of it have treated that value as 0, like no organ support free days. And there's another derivation that uses it as -1 to kind of demarcate that it's a separate level in this continuum of the survival, the observations that were observed among those who survived. Is that a fair summary of it?
I think that's a fair summary. And so you've got this -1 outcome that a patient died. 0 would then be that the patient survived, but they had 0 days free of organ support. For 28 days or 30 days, they might have been on organ support the entire time. Somebody who's a 1 survived, and they had 1 day free of organ support, and then 2, and then so on.
So, correct.
And so now that endpoint is a composite. It includes mortality. In the endpoint, it includes this. By the way, this shows up in all kinds of diseases. We do a lot of neurological diseases. You started in your undergraduate in neurology, but you can think of Alzheimer's, where you look at a cognitive test of an individual, and then you have patients that die in that process. And what do you do with death and cognitive decline is really the same sort of issue. We have this in acute stroke. We have individuals and we have their neurological status, and you have some that die. How do you do this? So in many ways, now you've created a composite endpoint. What I've been worrying out a lot about is, how do you analyze that thing? So, yeah.
Yep. Yeah, no, it's a numerical or statistical solution that has kind of just really, to me, intractable conceptual challenges. Like, how do you analyze a distribution? So then it brings back to something I mentioned a few minutes ago. You can look at it and you can say, okay, is it left skewed, right skewed, normally skewed? Then you can think about, like, well, do you want to prioritize certain shifts? Do you care about the shift between -1 to 0? It's just a lot of questions that I have not really been able to fully settle on. And that has always brought me back to the estimand framework, where I tend to look at these distributions and say, okay, well, now we solved the issue of what to do with death, but what do we actually want to extract from this solution? And I've never personally found the ventilator-free day or the organ support-free day to be kind of that attractive. So over the last few years, we've been spending a lot of time thinking about this methodology of the win ratio, which also has limitations, but I'm happy to talk about some of that concept and what I like about it a little bit more. Not maybe tons more, but a little bit more.
Yep. So my issue, interesting, the organ support-free days, we use that in RemapCap. We had a number of results that came out of it, and I think it worked very well. We did a proportional odds model across that, and it worked very well. And I'll say that because the distribution of those on active or placebo, when the clinicians looked at it and the statisticians say these are different, they looked at it and they said, that's clinically meaningful. And they thought they could explain the effect. And largely it's because in COVID, it was a very homogeneous disease. The effects were largely proportionate across the scale. They had the same effect on mortality. They also shortened organ support. There were some exceptions to that. So I think it worked because at the end of the day, the clinicians thought it worked in that. The huge thing I'm running into now is almost the way everybody analyzes this, there is a statistical model that comes out, whether it's the win ratio, whether it's the proportional odds, that creates a weighting of those values. Mortality is weighted relative to 0 through a statistical assumption, and that bothers me. I don't think that should be done. I think we need to go all the way, and this is very Bayesian. Perhaps maybe Bayesian is not the right word, but we need to clinically weight those states and analyze them that way. I think otherwise you're invariably going to end up with results you might not actually believe are clinically relevant.
Yeah. First, I would like to just at least modify my last comment. I may have not spoken. So I have no fundamental problem with any approach to composite outcomes. And I agree with you. They give you a summary of the net benefit of an intervention. I find that generally attractive. Yep. I've heard you and other people talk about this weighting scheme, and it's a very provocative thing, because sometimes I think we do think that we do other things like the win ratio and circumvent this issue, but we've just done it differently.
Yeah,
so
right.
Your point's well taken. I'm sorry, just thinking about, like, all these things get me really excited. So
it's incredibly exciting.
Not that it's exciting to talk about poor outcomes, but I feel this is, like, to me, one of the cooler and more challenging and such essential problems that exist in clinical research today. And as you mentioned, it spans so many different disease areas and pathologies, and better methods are so important. And and ways to incorporate stakeholder perspectives and weigh that in so that we can figure out weighting schemes that are really meaningful to the stakeholder distribution involved is such a kind of unicorn and holy grail that we spend a lot of time thinking about how to do, but haven't really quite figured out how to do well.
Yeah, and I feel like that's such a, as you started this, does it get you out of bed in the morning? And I feel like it's where we become really scientists, and we're using quantitative things to tie to clinical outcomes, and that's exciting. It's not a mathematical thing that we do back in our lab and is really neat, but it doesn't really help patients. Right. I brought up the B word in a question I ask a lot of people on here. Do you consider yourself a Bayesian?
Yeah, so as I mentioned to you in our email, like I didn't get a lot of exposure to Bayesian thinking before I was a postdoc, and really before COVID. And it was innovators like you who really, I think, brought Bayesian very much out of the shadows into the mainstream. And when I started first reading it, I found it so intellectually appealing. It just makes sense to me to think that way. I like to think on a continuum. I don't like to be, I realize that there's a decision theoretic component where you have to decide whether or not something's efficacious or not enough to move on it. But I like the probability and the posterior distribution. The other thing that I find very attractive about it, this is a long way of saying, yeah, I'm a convert. I still do a fair amount of like frequentist trials, and I appreciate a place for them. And I've heard other speakers, and I would like to think of myself as intellectually nimble enough to kind of choose among a set of tools for the task at hand. But I feel like Bayesian fits a lot of tasks at hand for me. So I'm increasingly trying to push people to do it. And I also feel like it makes a lot of sense, and this is where I was going with my answer, if I can tie it up, is when I was working on a lot of behavioral trials where we were trying to reduce people from smoking by giving them some type of financial incentive, or even in our healthcare system where we're just trying to nudge someone. So you're looking at 2 or 3 different, to me, very low risk interventions. Like, what is the harm of giving someone the wrong EHR alert? We're giving them too much money to stop smoking. So I always thought about like what errors meant versus just wanting to know if something's effective. So I kind of like the Bayesian framework because I don't find an intrinsic penalty of a p-value and minimizing p-value and alpha spending to be a meaningful set of constructs to guide me when I'm doing inference and a lot of the questions I'm asked to help people with. So I think for a number of reasons, I have circled back to a Bayesian framework to answer questions. And I realize there's a lot of discussion that could go on some of what I just said, and there's a lot of details in the new FDA report. But globally, I find that lens to be an attractive one to think about the broad array of questions in a lot of different areas that I'm asked to think about.
Yeah, and especially given all your work you've done in comparative effectiveness. You know, we have these phase 3 trials for a new molecular entity, and I get the 0.025 and a p-value makes sense. But if you're comparing strategy 1 to strategy 2 to strategy 3, the whole idea of hypothesis testing doesn't really work. And so within all of this setting, this makes a ton of sense. Yeah. Well, that's fabulous. The work you're doing sounds super exciting, and stuff that gets me out of bed in the morning and very interested in. So I'm glad that excites you as well. I hope as this develops and this center innovates, you'll come back on and tell us about all the cool stuff you're doing, Michael.
It'd be my pleasure.
Wonderful. And thank you for joining us here in the interim. Everybody will be here next time on the interim. Thank you.